Hi, welcome everyone. This is our first clinical seminar from the SIG CAF 2021-2022 officers. And we are here with Catherine Esperanza and Rosalie Prendergast. This is correct. And they're going to present about their works. And the idea today is for us to exchange knowledge and for people to really exchange their ideas and how they're working and what they have been exploring. So everyone feel free to, the girls will say if they prefer the questions during the presentations or after, but feel free to really engage and make this a rich change of knowledge. Catherine will be first, so please, Catherine, take the floor.
Okay, sounds good. All right. Hello, everyone. My name is Catherine Esperanza. My pronouns are she, her, hers. I'm a fourth-year doctoral student at the University of Texas at Austin, and I'm excited to talk with you all today. So today, first I'll just go over some terminology so we're all on the same page, some myths and misconceptions about asexuality. Then I'll talk a little bit about mental health in the asexual community, and then some contextual behavioral science strategies that may work well with asexual clients. And feel free to type your questions in the chat as you go or unmute. You can also ask them at the end. And no questions are off limits. Now's the time to ask them so you don't have to ask your client. So first, just why this training is needed. So first off, there's a need for asexual affirming care. So about 12% of asexual individuals in a very large survey, international survey of asexuals, reported difficulties finding identity affirming mental health care due to their sexual orientation. And ACEs who were out to some or all mental health professionals reported more difficulties finding affirming mental health care than ACEs who are not out, which shows that there are some barriers when you are out and trying to find identity affirming care. I oftentimes hear my colleagues say, oh, but I don't have any asexual clients. And about 70% of asexual individuals reported that they were not out as asexual to any of their mental health providers. And then also there's just a need for more education around asexuality. ACEs report experiencing mental health care because they expect bias, lack of knowledge, and invalidation from mental health providers. So for example, 48% of asexual individuals have reported experiencing excessive or inappropriate questions. And just in general, in my experience talking with other ACEs, I identify as asexual myself. I've just heard a lot of folks say that they're very exhausted of educating professionals. So it's important that we take time to educate ourselves. And just in general, training, education, and research on sexual, gender, and romantic minorities tends to leave out education about asexual individuals. And to your question on sort of what asexual affirming care means, we can talk more about that as we go, but there is sort of often a pathologization of asexuality. And so affirming and validating that identity as a valid identity and valid sexual orientation. And then specifically, I think why this is important for child, adolescent, and family clinicians, asexuals are more likely to be young. So about 16% are between the ages of 14 and 17 years old. And then they also tend to be younger than other sexual minorities. And despite that, there's still sort of a myth that you can't identify as asexual during adolescence. So sometimes people will say, oh, it's just a phase, or just wait and see. But that's not true. And then also if you work with clients who are on the autism spectrum or identify as transgender, you're even more likely to work with clients who are asexual. About 18% of asexual respondents identify as transgender in the asexual census, and about 8.5 had a professional diagnosis of autism. And there's some research that suggests that sexual and gender minority youth are more likely to come to therapy. So just some terminology. So what asexual means is someone who experiences low or no sexual attraction or they experience no or low intrinsic desire to have sexual relationships. And it's important to note that asexuality is a sexual orientation. So if you're wondering, like, how do I talk about asexuality with a client? It's pretty similar to how you would talk about any sexual orientation with a client. There's also aromantic, which is a romantic orientation. That's someone who experiences low or no romantic attraction or experiences no or a low intrinsic desire to have romantic relationships. It's really common to hear the term aspec, so like an aspec individual. That's the spectrum of asexual and aromantic identities. It's sort of an umbrella term. Allosexual is the opposite of asexual. That's someone who experiences sexual attraction of any kind. So if you don't identify as asexual or one of those spectrum identities, then you may identify as allosexual. And then alloromantic is the opposite of aromantic, someone who experiences romantic attraction of any kind. It's pretty common within the asexual community to hear people talking about the cisgender heteronormative society, or cishet for short. That's sort of the assumption that being heterosexual and cisgender and part of the gender binary is normal, and sort of the privileging of those identities and the gender minority over other sexual and gender identities. So for example, asking a woman if they have a boyfriend would be sort of the assumption that they're heterosexual. There's also normativity, which is the assumption that an exclusive romantic and sexual relationship is the universal goal for humans. It's normative and should be privileged and prioritized over other types of relationships, like platonic relationships. So you may hear someone say like, oh, we're just friends, sort of makes a hierarchy that romantic relationships, which involve sex, are above platonic relationships. There's a term aphobia, which includes acephobia and aerophobia, and that's just discrimination, bias, and negative attitudes, behaviors, and feelings towards asexuality and aromanticism, and people who identify as ace and aro. And there's allosexism. That's the pervasive system of discrimination and exclusion that oppresses asexual people and has that assumption that everyone does and should experience sexual attraction, and that being allosexual is sort of the best way to be and to live. So we often sort of only see allosexual narratives in the media. People sort of talk about sex as if it's sort of just a natural part of everybody's experience, but it's not. And then you'll see throughout my presentation SGM or SGRM, which is another way of saying LGBTQIA+, sexual and gender and romantic minorities. There's also another term which stands for marginalized orientations, gender identities, and intersex. So it also includes intersex, which I like. So because sexual attraction is such an important part of the definition of asexuality, it revolves around the lack of or low sexual attraction. It's important to define. Sexual attraction is the urge to have sex with another person, and that is distinct from sexual behaviors, which are the sexual acts that someone engages in, and sex drive, also known as libido, which is sort of that urge that's generalized without a specific target. It's not directed at a specific person. And that's an important distinction because asexuality is solely related to lack of or low sexual attraction, which means asexual people may still engage in sexual behaviors. They may have a high sex drive or they may have a low one, but that's completely unrelated to sexual attraction and asexuality. And then there's also different types of attraction. I think oftentimes sexual and romantic attraction are kind of sort of blended together in one, but they are distinct. There's also sensual attraction, aesthetic attraction, and many other types. So that's important to consider. Asexuality is a spectrum. There's lots of different identities and micro labels. And then within the ace community, you can have a mix of sexual and romantic identities. So for example, someone could identify as asexual and biromantic, or demisexual and heteromantic, or asexual and aromantic. I think oftentimes there's sort of an assumption that if you're asexual, you're also aromantic, which may or may not be true, depending on the individual. And then aromanticism is also a spectrum. I won't go over that, but I can share my slides later. So now I'll just go over some myths and misconceptions about asexuality, and then I'll go over some common missteps that therapists may make. And just before we start, I think now is an important time to kind of reflect on the different myths and misconceptions that maybe you believed in the past or wondered about before. As we reflect on our own internally held beliefs, that reduces the likelihood of engaging in a microaggression in therapy. And also, the more knowledgeable we are about misconceptions, the more likely we are to use microaffirmations, which are sort of intentional behaviors that support and reflect a valuing of a client's minority identity. And so now's the time to kind of reflect and look inwards as we talk about these things. So there's a common myth that ACEs don't have sex, masturbate, kiss, etc. And it just really depends on the person. So you don't want to make assumptions about your client. Not all ACEs are sex repulsed. Some enjoy it, some don't. Again, sexual behavior is different from sexual attraction. Again, sex drive may be high or low because libido is separate from sexual attraction. And some people may engage in romantic or sensual behaviors like kissing because sexual attraction is different from romantic attraction. Some people may masturbate or not because, again, sexual behavior is separate from sexual attraction. So just kind of a helpful mantra that can be helpful both for yourself as a reminder and also for your client, that action does not equal attraction. So people will often try to invalidate your identity based on the behaviors that you engage in or the actions that you engage in, but action does not equal attraction. Those are some definitions of sex positive versus sex favorable. You can look at those later if you want. There's a myth that asexuality is the same thing as celibacy. Celibacy is a choice versus asexuality is an orientation, and asexuals may still engage in sex. So that's, again, separate from celibacy. There is sort of an assumption sometimes that asexuals are also aromantic, that they can't fall in love or they don't want to or they don't date. Again, sexual attraction is not the same thing as romantic attraction. So it just really depends, and it's an assumption that you don't want to make. I've heard a lot of you can't know unless you've tried it. And again, like any other sexual orientation, you don't need to try to know your own sexual orientation. So for example, if you identify as heterosexual, you don't need to have sex of people with every single gender identity to know you are indeed heterosexual. So it's the same thing for asexual. And the other myth that I've heard, a lot of clients will tell me, people will say, oh, you just haven't tried it with me, I can fix you. That is a very scary comment to hear. So you may hear that from your clients as well. Another myth is that it's just a phase. It's not, but also it is okay if your identity changes. That doesn't invalidate your past or present identity. Sexuality is fluid, and that's okay. And it's a really commonly told myth to young people. And I have a lot of clients who kind of worry, what if my identity changes? And it's really hard for them to accept their identity because they're worried, what if it changes in the future? And so it can be helpful to know this assumption and to know that however you identify now doesn't invalidate how you identified in the past or how you may potentially identify in the future. There's also a common myth that asexuality needs medical intervention that's related to some hormonal imbalance. Again, if it's just sort of always been this way, if you've always had low or no sexual attraction, then it's probably not your hormones. If a client's libido drops overnight, which again, libido is not the same thing as sexual attraction, then maybe a client may need medical advice. But again, that's different from sexual attraction. So you kind of want to parse out what's actually going on. And also, you don't need medical intervention if you don't feel distressed about your sexual attraction. And it's important to parse out what's going on. Do you actually feel distressed about your own level of sexual attraction, or do you feel distressed about living in a society that privileges the experience of sexual attraction? So ACEs may feel distressed about a lot of things, but not actually about their own level of sexual attraction. They may feel distressed about how other people view them, about coming out, wishing they were like everyone else, but actually feel comfortable with their own level of sexual attraction and not want that to be any different. And when talking with ACE or questioning clients, it's really invalidating for the first thing you ask is like, have you gone to the doctor or have you gotten your hormones checked? That pathologizes asexuality. That can basically act as a form of conversion therapy. So that may be a question that you want to ask, but make sure that you first are validating and affirming of their identity, thank them for sharing before kind of jumping to talking about medical issues. There's also a myth that a client actually has sexual aversion disorder. Some asexuals may be sex repulsed, but if it's not something that bothers them, then that's not a disorder. And again, they may feel distress about sexual repulsion because of maybe internalized aphobia or because of living in a society that, again, privileges that experience. And also just, again, thinking about different ways that you may actually pathologize asexual people when you do. It makes us feel like we're broken people that we need to be fixed, when in reality, there's nothing wrong with us. It's just another way of being. It's another sexual orientation. So for the next minute and a half, I'm going to talk about asexuality and sexual trauma. So if you don't want to hear that, you can take your earbuds out for the next minute and join me in a bit. So there's also a myth that asexuality is due to a traumatic sexual experience or vice versa. You're not asexual or you can't be asexual. You're just dealing with past sexual trauma. The first point is sexuality is fluid, so technically anything could have an effect on your sexuality, and that's valid. There's lots of ACEs who haven't experienced sexual trauma, so you don't want to make that assumption that your client has experienced sexual trauma if they identify as asexual. There's also ACEs who've experienced sexual trauma, but that was actually after identifying as ACE. They may have experienced corrective rape, somebody trying to fix them, things like that. There's also ACEs who have experienced sexual trauma before identifying as ACE, and that sexual trauma has affected their libido, or they do have a sexual aversion, but that does not invalidate their asexuality, because again, asexuality is ultimately about attraction, not about libido or about sexual behaviors. And again, it just doesn't invalidate their identity and their sexual orientation. Asexuality is caused by depression or antidepressants. That's another common myth. Yes, antidepressants and mental health can affect your libido, but again, that's different from attraction. So some questions to consider. What part do you feel worried about? Do you feel worried about your low libido, or do you feel worried about your low sexual attraction? Do you feel worried about not engaging in sexual behaviors? Kind of parsing out those three different distinctions that we talked about, and trying to see what are they really worried about. And then also just, are they comfortable with their level of sexual attraction, or do they want it to be higher? Because maybe they're worried about their low libido, but they're actually comfortable with their level of sexual attraction and that being low. And so they're, in that sense, their asexuality is not caused by their antidepressants. They may have just noticed their asexuality more now that their libido is lower, but that low sexual attraction has always been there. There's a myth that adolescents can't be asexual, that they're just too young to tell. I've heard this from a researcher who intentionally didn't include asexual as a category because she said they're just too young to tell, and there's too many mental health issues for them to know that they're truly asexual. But the reality is, if adolescents can identify as lesbian, gay, bisexual, etc., then it's also not too early to also identify as asexual. And again, maybe a teen's label does change. We all change as humans and grow over time, and that's okay, and that's valid. We don't have to stick to one label for our entire lives. There's a very prevalent myth that sex is what makes us human. That's sort of a common narrative in society. Media often only represents allosexual and alloromantic narratives. It's kind of the one way to be and live and engage in relationships. If you open up Netflix, like pretty much most of the show. I got a message that my internet connection is unstable. Hopefully you can hear me. And first off, sex doesn't make us uniquely human because other animals have sex too, but also that is just one part of some people's human experience, but that is not the only way to be and live. There are many other things that make up our experience as humans. And then specifically some common missteps that therapists can make. So one is sort of doubting a client's orientation or assuming their client's orientation because of their sexual behaviors. So again, behavior does not equate orientation. So a client may be engaging in sexual behaviors, but that does not make them not asexual. Asking patients to educate and train their providers on their orientation. So obviously you may want to ask enough just so you can do some research on your own. So you may want to ask what their micro label is, but then do some more research on your own rather than asking them to educate and train you. Reducing asexuality to just a trauma response, sexual dysfunction, or a disorder. Trying to focus on a cause for the asexual orientation. You wouldn't do that for any other sexual orientation, so we also don't need to do that for asexuality. There are many different ways that people discourage or dismiss the use of labels, and sometimes people may try to be affirmative. So I oftentimes hear people try to be affirmative asexuality by saying, oh, it doesn't matter who you are or what you do, we're all just humans. And it's kind of a sort of like being colorblind. It's sort of a similar like orientation blind approach, but that can actually be kind of very dismissive of somebody's personal identity. Almost like, oh, it doesn't matter who you are, but like you don't have to share your identity. And actually, like, I am proud of my identity. I do like identifying as asexual. And so kind of being dismissive of that label and kind of ignoring orientation can be actually very dismissive. And there are many different ways that we can kind of pathologize or try to fix asexuality. And when a form of therapy or medical intervention does that, it can, in a sense, act as conversion therapy. And that's something to consider, especially given that conversion therapy, we all know that that's not good, and yet that still kind of happens for asexual individuals. So now I want to talk about some specific mental health factors within the asexual community. So asexuals, like other sexual, gender, and romantic minorities, experience minority stress, which involves internalized stigma, rejection sensitivity, or the expectation of stigma, concealment of your identity, discrimination and violence, and then the case of gender minority stress, also the experience of misgendering. And minority stress is in response to living in a society that holds bias and animus towards sexual, gender, and romantic minorities. So there's various different ways that minority stress plays out in the lives of asexual individuals. So for example, they may hold internalized aphobia. I oftentimes look at myself as a weird person because I'm asexual. And so I see a lot of different ways in which I hold that within myself and which I've seen that in others. A fear of being rejected by potential partners, being rejected by friends, family, just having anxiety about relationships or even trying to date or have relationships because of fear of not even being accepted to begin with. And so as such, there may be a lot of concealment around your identity, not sharing that with other people, having a lot of anxiety about coming out to other people. I think about my identity almost every day. Having to navigate in a world where I'm not out to a lot of people is something that can just have a lot of stress. There's also the experience of discrimination and violence, the experience of corrective rape, or anxiety about sexual boundaries being crossed in relationships or potentially being crossed at some point in time. And then there is also that stress of misgendering for asexuals who do identify as transgender. And in addition, about 25% of asexuals identify as non-binary and about 15% identify as agender. So that's something that you may come across with some asexual clients. And then there's sort of just the general stress of navigating relationships and friendships and other types of relationships in the broader culture that sort of prioritizes being allosexual as the way to be. There's sort of a broader culture of hookups or dating to get to know someone, which may not be how you want to approach relationships. And then there's also just a lot of erasure and lack of representation in the media and in society. There's that common phrase, sex sells. And so media is oftentimes very highly sexualized. It can just not really feel very relevant or very relatable. And then there's also some sort of specific mental health concerns. Asexual youth have significantly higher internalized phobia than other sexual minorities. So they hold sort of more aphobia than other sexual and gender minority youth. Asexual youth and young adults report greater depression and anxiety than other sexual minorities and heterosexual youth. Asexual young adults experience significantly greater suicidal ideation than non-asexual young adults, and that's while controlling for gender minority status, which is important because we also know that transgender folks experience very high rates of suicidal ideation and attempts. And then there's also just a experience of bias. So there was a survey of heterosexual individuals about their attitudes towards bisexual, homosexual, and heterosexual folks. And these respondents evaluated asexuals more negatively than bisexual, homosexual, and heterosexual people. They saw asexuals as less human than the other groups and were more likely to avoid contact with an asexual person than with members of other groups. So oftentimes people say like, oh, asexual, like there's like no experience of bias, but there actually is a lot of negativity and bias that we see frequently, especially on the internet as well. So now just some considerations for therapists and some specific contextual and behavioral strategies. So first off, just having an affirmative stance. It's not just enough to say like, oh, I'm LGBTQIA plus affirming. I know a lot of ACEs who are still wary when they see that because they're not sure if that therapist is specifically asexual affirming. So some ways that you can demonstrate that is by, if you have an office, having asexual books and reading materials. You can have an asexual flag. You can make sure to include asexual as an option on paperwork. Just being aware of language that you use that may assume asexual, allosexual, alloromantic, heteronormative, and binary norms. Then also just live an affirmative life by being involved in advocacy, having conversations with others when you hear something that may be allosexist, making sure to use the correct terminology and labels for your client, and then just engage in regular self-reflection like you are doing now. So now specifically talking about contextual behavioral science and third wave CBT strategies. So the first one, clients who are asexual may experience a lot of rumination. As I mentioned earlier, there's just a lot of anxiety and anxious thoughts that an ace person might experience. There might be rumination that comes up when feeling uncertain about your asexual identity, just like a lot of worry and thoughts about that. A lot of rumination about coming out. Should I do it? Should I not? And just kind of living life concealed or not out to others. There can be a lot of rumination there. And then also just intrusive thoughts about past experiences of discrimination or violence or fears about that. So mindfulness can be a strategy. It's shown to help reduce rumination, including in sexual and gender minority populations. I will point out one thing that because a number of asexual clients are also transgender, it's important to consider that a lot of mindfulness draws attention to the breath or to the body, which may be uncomfortable or dysphoric to transgender clients or to clients who wear binders. So it's helpful to have mindfulness strategies that don't just involve drawing attention to the breath or to the body. And another way to address rumination is using perspective taking. And the purpose of perspective taking is to develop a deeper experiential awareness that our thoughts, emotions, and sensations can vary from different perspectives, from the perspective of the past or the future, from the perspective as an observer versus from your own perspective and across different contexts. And that practice of perspective taking from research shows that it promotes psychological flexibility, reduces rumination, and increases self-compassion. So this can be particularly helpful for asexual clients who are already looking at themselves from a lens of possible future negative outcomes. So for example, I've heard a number of ace folks say, I'm going to give up dating forever because I'll never find someone who will accept my asexuality. So they're kind of looking at this possible future negative outcome and letting it affect them in the present, rather than holding open the potential for the unexpected and for different experiences. And so perspective taking can help open somebody up to the potential for potentially different outcomes than expected. There's also a lot of internalized stigma, and acceptance can help respond to that internalized stigma and internalized aphobia. And it's important to note that acceptance as a therapeutic intervention does not mean passivity towards the status quo or having a hopeless stance towards your experience in your context. So I think oftentimes when we present acceptance, it can sound like we're saying, oh, just accept things as they are. And it can sound like we're saying, just accept the status quo. The status quo is okay. And that's not what acceptance is. And I think that's important to know that distinction for yourself and also to share that distinction to your clients. Acceptance is just a stance of willingness to be with all of the thoughts and emotions, memories, external aspects of one's own current context that are accessible within the present moment without trying to push them away or without trying to control that experience. So what happens is asexual individuals, they may engage in avoidance or attempts to control their exposures to unwanted thoughts or emotions or behaviors related to their identity. So they may withdraw from other people who they're not out to avoid thoughts about and worries about coming out. And so what acceptance would be is just the power to kind of step back, notice the oppressive system that you live in, notice the aphobia without allowing it to define yourself, and really see the reality, step back from it, and then proceed mindfully in the interest of changing it. So you may feel like, oh, I'm weird because I'm asexual, and that's allowing that to define yourself, and then kind of stepping back and saying like, yes, there's aphobia. And so people may look at me as a weird person, but that does not define me. And then I can go and move forward in the interest of trying to change society. And I don't have to accept the status quo, but I also don't have to let the status quo define me. And then there's ways that we can encourage our clients to live a meaningful and fulfilling life using committed action and willfulness. And so oftentimes as ways to cope with environmental threats and with interpersonal challenges, clients may engage in effective short-term solutions that really affect their long-term well-being. So for example, an asexual client may decide over and over again not to come out to their partner as asexual because in the short term, it reduces likelihood of conflict. And so it feels good in the moment. They're like, okay, I feel relieved that I didn't say anything. But in the long term, they may live with fear that their partner will eventually reject them one day. They live with self-alienation. They feel alone and isolated, that no one knows who they really are. And so in the short term, they're engaging in coping that's effective, but in the long term, their well-being is really negatively affected. And so you can use willfulness and committed action as a way to help a client. And willfulness doesn't mean that you're kind of pushing through hard times. Instead, it means that when we recognize and choose to live our values, we're recognizing that that co-occurs with other unwanted experiences. So oftentimes anxiety, depression, fear will hook us and pull us in the direction away from our values. And so with willfulness, we decide to choose in the direction of our values, even though we know that with that, we will hold some fear, some anxiety. And by living openly and authentically, we know we have no choice but to open ourselves up to unwanted experiences or mean comments or the possibility of discrimination, but we are still choosing to live openly and authentically and in line with our values, rather than letting fear continue to drive our lives. And we can also choose when and where we share identity. So sometimes it may not be safe to come out, but we are deciding to choose rather than sort of always letting fear and anxiety hook us and pull us away from living in line with our values and living out our lives the way we want to be. So one strategy that I like to use with clients is just asking, what's the smallest possible step that you can take to live your life as authentically you? Sometimes it can feel really scary, like, oh, I'll never be able to live who I am until I come out to everybody. And so what's something that you can do right now, even if you're not out to everybody, what's something that you can do now, a very small step, so that you can live your life as authentically you. That might just be watching a documentary on asexuality that makes you feel validated and affirmed, or reading a little bit of Reddit or something. Even if you're not out to everybody, but you still feel affirmed and authentically you in that moment. There's also, you can use willfulness as a way to reframe coming out. Coming out can be very scary. It sort of implies that you're exposing yourself to the rest of the world, versus coming in implies that you're inviting others to learn more about you and to grow along with you. And so the way that you can reframe coming out as a form of willfulness is that when we come out to the big scary world, we're also simultaneously coming into our full and authentic selves and choosing to live in line with our values. And so both of those things happen at the same time, but by coming in, that can help us resist some of the negative things that may come with coming out and the negative reactions that it may bring. And also, coming out is sort of portrayed as this thing that we do for other people. It's a big thing, or it's a one-time action, versus coming in sort of allows ourselves to embrace this process of continually moving in the direction of our values and choosing how and when and where we show this part of our journey to other people. We'll be continually faced with choice points to decide whether or not to share this part of ourselves with other people. And so we can kind of view it more as a process, as a journey, and as a decision to invite other people to learn about our authentic selves and who we are and to grow with us. We can use self-compassion to combat shame. There is a lot of pathologization of asexuality, which implies that something is wrong with us, that we're broken, that we're not whole beings as asexuality. And even though it's not a mental illness or a sexual dysfunction, a lot of people still see it that way. And so self-compassion can be used because it's the opposite action of shame. And so shame, it orients us to look inwards, it overwhelms us with pain, and it makes us self-critical. And so we assume that this pain is deserved. And with self-compassion, that encourages us to consider that pain is human, it's part of the human experience. And that helps us to connect with other people rather than to isolate and withdraw ourselves. And then by accepting that, that allows us to then change and encourages us to remove that pain and recognize that it is not deserved. Oftentimes we kind of feel like, oh, we deserve to feel this way and to feel horrible because of that shame. And so when we accept that we don't, then that allows us to then make changes in a positive direction for our mental health. And then another way to combat shame is just by encouraging community connectiveness, to connect with other asexuals, to see that we're not alone. And it is one thing to note that not all LGBTQIA+ spaces are welcoming or inclusive of asexual individuals. So there also may be some navigating there to find a space that is accepting. I see oftentimes in different internet communities, a certain LGBTQ+ community online will say the A doesn't stand for asexual, aromantic, and agender. It stands for ally, as like a way to kind of exclude asexuals. So that may be something to help your client in navigating as well. And then distress tolerance from DBT can also be very helpful, just sitting and coping with thoughts from internalized stigma. And I found that distress tolerance is also very helpful for transgender asexual clients who are coping with gender dysphoria as they're either waiting for medical transition or in the process of social and medical transition, and are trying to cope with various dysphoric thoughts. And then just some other things to think about is what do I say if my client says, I'm not sure if I'm asexual? How do I know? You can thank them for sharing, share your affirmative stance of all orientations, including asexuality, regardless of where they end up. You can ask them what resonates about asexuality with them. You can kind of explore with them their experiences about sexual attraction versus libido versus sexual behaviors. And you can encourage them to read personal stories from other ACEs to see if those stories resonate with them. And for time's sake, I can share my PowerPoint later that has a number of different resources, different websites, different books, different podcasts, resources for helping clients find online communities. I feel like navigating boundaries is a big discussion in the asexual community, so there's some resources here. And then also ACE-friendly sex-related resources can be especially hard to find, so here are some here that you can look more into later. And then I have my references. And that is my presentation. Thank you so much for listening to me today.
Thank you, Catherine. Thank you very much for presenting and for sharing some of your personal experiences. I would like to open the floor for people willing to ask questions or to make comments about the presentation.
I would just, wonderful job. And it's just so amazing how timely things are. I have a client that's in kind of just your whole presentation is going to be so helpful for me in navigating, supporting him, and just all of the language that you included. That was invaluable to me. So thank you.
I'm so glad to hear that. Thank you for sharing.
I definitely echo that. I wrote down 20 questions, so I know we don't have time for that, but one thing I could ask you maybe quick is, what in my experience clinically, often a common path in for therapy for gender and sexual minority youth is really invalidating experiences with their family. Could you speak to how you might work with parents, for instance, or other family members when there are transgressions there?
Yeah, that's a great question. I would say one thing that I found helpful, it's not contextual behavioral sciences, helpful is the use of motivational interviewing, which is helpful for folks who are ambivalent about change. And using that strategy with families can be really helpful, letting them know your affirmative stance, but also kind of using motivational interviewing strategies, using open-ended questions, affirmations, summaries, reflections, just to kind of explore their ambivalence about their child's identity, and their ambivalence to be more open to their child's identity has been really helpful. Otherwise, if we kind of try to go at them like wanting them to change, it can make them even more resistant, which is what most people do. And it can be very hard to kind of approach them with that sort of openness to their ambivalence. But that can be kind of helpful in my experience with sort of navigating those conversations and kind of moving them towards more openness towards accepting their child's identity, or just being a little bit more open to letting their child have that identity.
It makes total sense to me, because the natural way for a parent to be is to support their kid, right, and to love them. And then they find themselves in this position when it's like the robot kind of breaks down, like doesn't compute kind of an idea. So yeah, I guess there is natural ambivalence there. So that could be a missed opportunity for a therapist, I think.
Yeah, that's a very great point.
I have more, but I'm going to put myself on mute first.
Thank you for your question.
I have a question that I'm not sure how to formulate it, but what I'm thinking about is I usually work with very close-minded families, if I can say like this, families that are almost scared of their children being different from the norm. And sometimes I feel like there's a lot of concern from the parents when their kids start either showing up signs of that they may be not cisgender or anything like this, in the spectrum, but also that they are not, for example, initiating interest in any sort of sexual activity. And my understanding is that knowing about their sexuality is something that is lacking in general. And I wonder if, for example, sometimes clients may be asexual or may understand that they don't know they are because they don't know that's a possibility. But I understand that sometimes if it is unethical for us to present it as a possibility because we might be influencing someone who's very young and sometimes very unknowing of what's going on with them, how, maybe a question would be, how would you help someone that you feel that may be, I don't know, showing signs that they're, say, sexual, but without telling them, oh, go look it up because I think it might be helpful for you because it may be, I don't know, as advertising. I don't know, I feel insecure about asking questions and being disrespectful, but do you get what I'm trying to test there?
Yeah, that's a really great question. And you're right, a lot of people may not even know that the asexual orientation exists and that it's a way to be and to live. And so that's something that we may want our clients to know about or potentially explore without pressuring them. And so I think the first thing I want to say is just with any other sexual orientation, we would want our clients to know that it existed. If they weren't heterosexual, like we would want them to know that other orientations exist. And it's the same thing with asexuality. I know, like when I personally heard the word asexual and what it meant, I was like, oh, this is me. And I really felt like I found my home and I had come into my own. And my whole time before that, I felt like something was wrong with me and I was broken and I needed to be fixed until I found, oh, this term exists and this is me. And actually there's nothing wrong with me. There are people just like me. And so it can be helpful to present sort of the whole menu of options and just let someone know that they exist. Otherwise, we're kind of denying them the opportunity to realize that there's something wrong with them, that there is actually a community of people just like them. And so there's different resources. For example, there's like the Gender Galaxy, which has both gender, romantic orientation, sexual orientations. And so you can do that with your clients. That's something that I do with a lot of my clients, just to explore different aspects of gender, sexuality, romantic orientations. And in that way, you're not kind of saying like, oh, you should look into this one thing, but just sort of exploring all different aspects of who they could be and kind of letting them explore sort of the galaxy of different orientations and identities out there. It's one thing I like to do with my clients. I don't know if that's helpful.
That's very helpful. Thank you.
Thank you for your question.
Do we have more questions? Do we have more comments? Shen, go ahead.
Well, a lot of my comments or questions had to do with the theme that was running through a lot of your presentation about the self and how that unfolds across development and lifespan. So there are a lot of themes that go along with that, is why maybe self-compassion is a good, or kind of needed thing for many folks that identify as asexual. And then could you speak just a little bit more to how you might approach that naturally with a client, where I know everyone has their style and a lot of folks who are working with CAF populations are often blending other traditions in with ACT or DNAV or other approaches. And some people are more, we're going to use what the conversation naturally is giving us, or have these, the toolkit of exercises, these kinds of things. What is your clinical wisdom showing you about addressing that dimension of things?
Yeah, that's a good question. I mean, I personally also like to do kind of a mix. Following the lead of my client, I think, can be helpful in sort of navigating the self. And I also like to use mindfulness just as a way to kind of be able to access and sit with those thoughts that you may have about the self. Sometimes there's so much like avoidance of different thoughts about who you might be. And so just kind of being able to sit with them and engage with them can be very helpful. So I think that's a strategy that I like to use, just to be able to kind of explore the self a little bit more and your identity and who you may be. And then I think that what comes with that can also be a lot of distress tolerance. So in moving towards who we are and living our authentic selves, there can be a lot of distress. I know I have transgender clients who go and try to dress in a way that aligns with their gender, and then they feel a lot of distress about how other people may perceive them. And so then they don't do that. And so being able to engage in distress tolerance can also be very helpful in sort of being able to explore yourself. Oh, I'm so sorry, we have a visitor. And so I find that also very helpful in the exploration of just yourself and your identity.
Cool. Thank you for sharing on that.
Hopefully that was helpful and answered your question.
We have time for one more question before we move on to Rosalie's presentation. Does anyone want to hop in and ask anything?
And I can also put my email in the chat if you have questions that come up later, or if you feel more comfortable asking them offline, that's okay too.
Thank you. That's
I mean, I have one more that I could
Go.
ask if.
Yeah.
My goodness, here we go. So the other thing that I noticed is discussing values, and then all the societal pressures and aspects of dysphoria can make it really tricky to figure out, especially as values and those ideas of what we value for ourselves is in flux or kind of developing in the adolescent years. How do you kind of use your clinical ears to develop when it's not really a value per se, but maybe more, this might solve something about dysphoria for me, or that I think I should, kind of value this more? How do you approach issues like that?
Yeah, that's a very good question. So I think, can you hear me? Sorry, I just got a message.
Yeah, you're back. You're back.
Okay, perfect. So I think that's a very good question, and that is something we see a lot, that what kids are sharing as values aren't really values, right? Because they're for somebody else, or therefore sort of to fit in better with society. And so I think first off, being able to really clarify what values are, and if something is meaningful to them, is it really meaningful to them, or is it because it's a way to assuage their parents or to fit in with norms? And so I remember reading one book by Stephen Hayes, where he talks about like how to talk about values. So asking like, why do you like this Diet Coke? Oh, because it tastes good, or because this, like, no, why do you like it? And it's like, just because I like it. And that's ultimately what a value is it's just because I like it. It's just for me. It's not for any other reason. And so kind of using like those metaphors can kind of be helpful, where it's like, okay, why do you hold this value? Oh, for my parents or for this. Okay, then that's not really a value, right? A value is something that is for yourself. And so I think first kind of clarifying that. And then I like the idea also of kind of willfulness to, there may be times when sort of norms or different things may make it so that we don't move in the direction of our values for safety or for our parents or whatnot, but then also deciding that sometimes we do want to move in the direction of our values, even though that will come with some negative experiences and reactions. And so I think also the idea of willfulness and the idea that we can move in the direction of our values, even though that will come with negative things, that sometimes positive changes also come with some negative, and that's okay too. And then there are also times which we have to not move in the direction of our values in order to keep ourselves safe. And that's also okay too. That doesn't make our identity any less valid or who we are any less valid. Sometimes we do have to do things that keep ourselves safe.
Complexity, right?
Yeah, there's a lot of nuance there.
Yeah, I love that.
Yeah, I think it's helpful to also just kind of brainstorm some different ways that you can be authentically you,
Right.
even if you can't be out to your parents or different things. Sometimes there's sort of an all or nothing approach. Well, if I'm not out, then I can't be asexual at all, or I can't be this at all. I can't be transgender at all. And so again, sort of thinking about what's the smallest little thing that you can do to still live authentically as you, even if that doesn't mean being out to your parents, but it means you wear purple because that's an asexual color, or something that just makes you feel a little bit like you, rather than it's like, I'm either this or I'm not anything at all, and I can't be myself at all. Kind of finding some middle ground can be helpful.
Yeah, balancing out maybe the authenticity with psychological safety and whatever the moment offers. I like it.
Yeah, that's a
Cool.
great way to phrase that. Thank
Nice.
you, Sean.
Thank you.
Thank you, Catherine. I learned so much from you, and my mind is like boiling up with ideas and ways that I, for example, can make my office more friendly for people to recognize that I'm an ally and stuff like this. So it's been so helpful to hear you, and I'm sure it's been important for everyone. Thank you very much for being here and for being willing to talk to us. So now I'd like to invite Rosalie to talk.
Sure. So please, everybody, feel free to interrupt, raise your hand or unmute and chat during this. I've condensed kind of 10 years of programming into like a half an hour. So I think there might be a few questions, so feel free to interrupt me. I also can get talking a little bit too much and a little too fast, so don't hesitate to prompt me to slow down as well. All right. So I am going to talk with you guys today about the happy medium approach and happy medium language. So it's a behavior analytic approach that supports individuals using language as intervention and then moving into actively practicing psychological flexibility. So who can benefit from the happy medium approach, or HMA or HML? We've used components of this approach with individuals from 18 months to, our oldest client was 96, that we've used kind of components of this approach to support. A lot of the individuals that find the most benefit have dual diagnosis, maybe an ASD and an ADHD, or an ASD and DMDD. And some individuals have had no diagnosis at all, just some challenging behaviors, some dangerous and unsafe behaviors. So some characteristics that you might observe from individuals that we've supported with this approach are awareness of the world around them is kind of low. Their ability to kind of label events, it might be low, or it might even be hyper-focused. They might be super stuck on some things, but not able to observe and notice other things. They generally have challenges understanding and regulating their emotive states, and even recognizing changes in those emotive states. They can have a hard time communicating before using big behavior to get their needs met. So their go-to might be punching a window out before saying, I'm mad that you didn't get me a cup of milk fast enough. They might need support sustaining engagement or even broadening their areas of interest. So they might be like a Harry Potter fan. I'm going to watch every single Harry Potter movie that exists. I'm going to read every single book. And then once they've kind of completed that series, they've got nothing else to engage in. So we might see some behavior in that area. Their tolerance to different contexts might be low. So they might be able to tolerate, the home environment, but then you move to school and their tolerance drops. It's very low. Or even, they tolerate working with one parent, but then have a lot of tolerance challenges with another parent. And they can easily develop not helpful rules, and kind of tracking how their behavior works for them, especially towards things that they really care about, can be very challenging at times. And they also need support monitoring their own behavior. Parents often say, like, he wouldn't wear shoes to school if I didn't remind him to wear his shoes, or things like that. And they can have a hard time with perspective of others. and often kind of misinterpret environmental events, especially with peers. So that's kind of an outline of kind of who this approach was built for over time. So what's the purpose of happy medium language and the happy medium approach? We usually do the first two steps kind of together. We're going to use direct contingency management to reduce large and unsafe behaviors, and we're going to increase a foundation to learning. At the same time, we're going to use language as intervention to develop contextual awareness, increase those relational networks, support some transformation of function of stimuli, so that they can respond effectively to changing contexts. And then we move into kind of accessing and practicing psychological flexibility. So really notice and choose to persist or change behavior in the pursuit of what's important to the individual. And then we move into using, the Thriving Adolescent or Connect, DNAV. DNAV is really the kind of lens of happy medium when we're thinking about kind of that psychological flexibility model. But sometimes our guys don't have the foundational skills to access that full curriculum. So the happy medium approach supports us in getting to that point. So the point of view of the happy medium approach is this noticing grid. It acts in so many different ways. It's our ability to support individuals in noticing their different regulatory states. It supports us in helping them to track the behaviors that they're using. Are they going to get me where I want to go? Are they going to help me contact what's important to me? So our first little language pairing that I'm going to introduce you guys to is too big, too little, and just right. And these language pairings are taught in a very flat and neutral way. So it's just a label, like you would be teaching a label for, like, my shirt is brown and, a darker brown. It's nothing, we're not going to have any intent in there. We just want them to be able to label their reactions as to whether or not it fit the context that they're currently in. So our first level on the noticing grid is a level 1. Other kids like green, yellow, red. I had a kiddo do tigers. So a level 1 was a cat, and then we had a tiger, and a lion was level 3. Another individual chose to use chili peppers and how hot chili peppers were. So, a not very hot chili pepper was a level 1, and then the poblano was a level 3. So we provide them with a lot of flexibility in how this noticing grid is set up so that we can support them in being motivated to use it. So along the side, we've got our level 1, which is just right, calm, slow, engaged. Our level 2, we're starting to get a little bit too big. We're moving too fast for the environment, but we're not yet in a dangerous or unsafe place. And then our level 3 is when you're clearly too big for the environment. That's where our big undesirable behaviors go, like maybe eloping out of sight, hitting, kicking, biting, going to the bathroom in places that are outside of the toilet, things like that. So across the top, we have our first column is what people will see. So we want to list out objective behaviors so that the individual and any of the intervention team or family members can be very sure that they can correctly label what level of kind of engagement that individual is on. Are they at a level 1? Are they at a level 2? Are they at a level 3? And then our next column is what are other people going to do? So at a level 1, those are a lot of our reinforcement strategies. If you're talking out loud, we're going to do our best to turn things into a yes for you. If you would like to compromise and you want to say out loud, I want to compromise, but we're going to try and offer you a compromise. As we move up on the noticing grid to level 2 and 3, those become our intervention kind of reaction strategies. What are we going to do to support you to get back to a level 1 if you're at a level 2 or at a level 3? And then I think the most important column is our last column, which is how can I get back to a level 1? And then more importantly, when I'm at a level 1, how can I sustain my regulation to stay at that level 1? Maybe with a few doable pops to a 2, but then I'm able to utilize strategies and get back down to a 1. Yes.
Rosalie, how do you do your reaction's too big for the situation without sounding maybe unvalidating or something like this?
Oh, that is a great question. So it's literally a label, and we use our incredible 2 rule, which is we'll say it twice and then we're kind of done. It doesn't end up being a big discussion. It's literally just a label. So and we generally, when they're at a level 3, we're not talking a lot, but we might be saying once or twice, just labeling, that's too big. For example, if somebody's, peeing in the classroom, I'm kind of going to be stuck on that now since I used that example earlier, but, we're going to label that just once, that's too big. And then we're done talking about it, just so that we can help them see that doesn't fit, but we're not going to get stuck on it. And we're not going to make it kind of so that it is invalidated. They're having a hard time right now. We need to be there supporting them, but we also need a way to let them know that that doesn't really match. And if one of your personal values is making friends, kind of peeing in the classroom is not going to be a good way to get there. Did that answer your question?
It's sort of focusing on workability without like really, this is not working, this is working more than, and sometimes maybe I understand that this is hard for you, but it's not working. Like focus on the workability part of it without getting stuck on how you're feeling maybe.
Totally. Yep. Exactly.
Do you also, I'm sorry, do you also use the noticing grid during the sessions?
Yes. So this is a whole team approach. So we teach the individual.
You teach the parents, you teach the school, you teach the whole system.
Yes. And the goal is to get the individual to be able to label what people are going to see or what they're going to hear. And sometimes we even get to a great spot where they're able to say, hey, I've got these things going on inside. I have these private events.
Yeah, sure.
That then they're able to report those. So we're able to then add those to the noticing grid kind of as their skills increase. And I'll show you guys some examples of a couple of noticing grids here in a minute. And you can see one is kind of from, let me just jump over there because I think that's an important piece. And then we can jump back and forth.
Just as you're doing that, I'm noticing too, Rosalie, that there's not a lot of pushing around consequences as a way of changing behavior. So this is very much trying to get the noticing and shaping. Am I getting that right?
Definitely. Yeah, we want that individual, and this individual wanted his noticing grid. He wanted level 1 on the top and level 3 on the bottom. So that was a flexibility piece for us. So, but you can see he's able to now, he can kind of track like, oh, look, when my body's just right in school, people are going to talk to me. They're going to listen to you. They're going to compromise. They're going to give you choices. They're going to follow your play ideas sometimes. And then as we kind of go up in level, obviously we're trying to stay at a level 1 and a level 2, where we're using behaviors that match the environment or closely match. We don't want to be stuck in this level 3 zone. I think especially after, listening to a lot of individuals, autistic individuals who have been through ABA, that extinction piece is very kind of dehumanizing to them.
Yeah, for sure.
So we want to go slower in our interventions so that we don't have to get to that level 3 where we have to keep you safe. We've got to move things to keep them safe so that you don't throw your computer and break it. We're not going to talk to you during that time because I think anything we say is, in one ear and out the other. And we're going to block you from hurting yourself or others. And we're going to wait for you to slow down. And for this individual, there were a couple of toys that did become a no when he would get too big to a level 3, if it included kind of aggressing against his brother. So, but again, we want to try to stay out of that level 3 zone because there isn't any learning that's happening there. All we're doing is managing the environment and trying to keep everybody safe. So we want to stay, so you can see Louisa there on that level 2 too, is say too big. I am too big, but also say how you're feeling. So, I'm feeling mad right now. I'm getting too big because of this, this, and this. So we want to support that development of those skills rather than just kind of labeling you're too big. So it's always paired with learning. Does that make sense?
Yeah, definitely.
Okay, let me show you guys another noticing grid that it really kind of highlights this individual. Again, he wanted 1 at the top and 5 at the bottom, which no biggie. It just takes us adults a little bit of flexibility to, you know, to be like, oh wait, what am I looking at here? But you'll hear in or see in his noticing grid, there's a lot of languaging about emotions and things like that. He started off with a 1 through 3. And about 6 months into treatment, he was like, this doesn't work for me anymore because I have more skills now. I need more levels because I can tell the difference from when I'm at a 2 and when I'm at a 4. So kind of 2, 3, and 4 used to all be lumped together. And then he was like, no, these are different levels of you know, emotional dysregulation for me, Rosalie. We've got to change this up. So he has a much kind of broader group of behaviors and repertoires that are at each level. Did that help to see those examples?
Yeah.
Very helpful.
How old is he?
So this individual is currently in 7th grade.
Okay.
And then this individual, he was 5 when we started this. So everybody's a little bit different. And I've got a couple more. So this is a 9-year-old, and this is an intervention noticing grid because this school team is very, I'm going to try to say this in a friendly way. They're kind of stuck. So we needed one that was for just the intervention team. And then he has another one, but you can see he also added in that blue zone and that orange zone because he felt like this just wasn't enough for me. I have different levels now. I'm not just a green and then a red. I now have in the middle. I can move kind of from green, then yellow, then orange without getting to red. So he added a layer in as well, kind of in the middle of intervention. That help everybody?
Yeah.
Yes, thank you.
Perfect.
Awesome. It was so hard to order all of this. There's just a lot. So our happy medium language pairings that start right away with our direct contingency management programs, like when we're working to reduce those level 3 behaviors, increase level 1 and increase level 2 on the noticing grid, we utilize these language pairings for the entire intervention team and really kind of the individual, the context, to have a similar language in order to label environmental events so that we can reduce those kind of misunderstandings on the environment that lead to increased behavior. So we can also support kind of layering of these. So for example, a lot of the individuals that we work with have a really hard time when they lose a game. So the first thing that we teach is a competitive game versus a non-competitive game. So competitive games like Uno or Trouble or, you know, Foursquare. Non-competitive games are things like eating lunch, walking in line, being first to the car. I don't know, I'm sure some people have had some experiences around similar things like that. So we teach kind of what's competitive, what's not competitive first. How do you stay at a level 1 when you're playing a competitive game? How do you stay at a level 1 when you're playing a non-competitive game? And then we might throw in or layer on there, you know, playing a competitive game can be fun or it can be not fun. It usually turns out fun when you win, turns out not fun when you lose. But then we might even add in, but what is the big picture? What's the main idea of playing a game with friends? It's playing a game with friends. That's pretty awesome. And that turned out fun. So we support them in developing all of these different ability to interpret the environment in a way that will support their ability to sustain a level 1. And I put the three that we teach first including that too big, too little, just right, are at the bottom, which is our sometimes circle. It can turn into a yes or a no when it happens. A lot of our individuals will make up not helpful rules, like every time I ask for a lollipop, it needs to turn into a yes. And then when mom or dad say no, because it's 7 in the morning and they just woke up, we got a level 3 behavior on the noticing grid. So we support that individual in understanding that sometimes lollipops can turn into a yes and sometimes they turn into a no. And we use multiple exemplar training for all of these language pairings to support them. And we might prioritize them in different ways based on how the individual is presenting in the environment. Yes.
How would you use these language pairings? I mean, would you use them as a specific activity? For example, today we're going to learn about these opposites. Or do you, for example, have these cards hanging around, and when you are in a situation that you see that involves sort of the need of these discriminations, you would like pop them up and oh, so we have a competitive, non-competitive situation, for example?
Totally. Yeah, we provide this as naturalistically as possible. But we still need to make sure that we get enough opportunities for them to learn. So we have these language pairings laminated, and basically they're attached at the hip to all of the therapists, and they're in each intervention area, so that when the opportunity arises, we can quickly grab it and roll with it. And then sometimes if we're needing to create more opportunities, we will kind of try to arrange the environment to make that happen. Does that help? Sean, I see your hands up.
Yes, thank you. I think you answered part of my question about some of these details here. And I'm hearing from your last response that you often have them physically posted in areas, so it's not, not missed. It's like part of the environment that way, and that helps for the multiple exemplar training too, maybe in a little less formal way. Are you taking data in kind of an intensive way like an ABA program too, or how do you do that part of it? Maybe you'll get to it, but I'm just curious.
Yes, so we take data depending upon the individual, but mostly we take data on, are they increasing use of labeling the environment using these labels and definitions? Sometimes we'll take data on specific language pairings, like the thinking in your head and talking out loud. That one, it tends to be, it seems like such a simple concept, but it's not. A lot of our kids have that challenge with theory of mind. They think we know what they want. And, and then when we don't meet their expectations because they didn't say anything out loud, we get those level 3 behaviors. So for some of these frames in particular, we will take individual data on them. But overall, generally, we take data looking at, are they increasing the frequency that they're labeling? And then we pair that with taking data on, which I'm going to show you here in a minute. Are they increasing their ability to sustain a level 1 on their noticing grid?
Got it. So if I could try to talk that back to you and see if I understand, you might take data on any of these, depending on where you might see this being almost like a keystone for an individual client. Am I getting that right? And then you might take data and then you get a breakthrough and then you wouldn't track that anymore. That kind of an idea? Okay.
Exactly. Yeah. Like I think I use, so expected and unexpected is one of those as well. A lot of the individuals that we work with, like unexpected is not fun. It's bad. Nothing good comes from unexpected. They want everything to be expected. So we might target that one heavily right off the bat and pull out a lot of like things that we know they enjoy and deliver them in an unexpected way so that we can start helping them unpair unexpected and not fun and pair, oh, sometimes it does turn into a yes for something unexpected to turn out fun.
Oh, that's so cool. So you're not like trying to teach it like a classroom, you're literally showing them through their experience and you're arranging it so they can learn that.
Definitely. Yeah. So a lot of people have kind of tried to teach this kind of like you're teaching a lesson. And you have to pair it with them contacting something that's valuable to them. Otherwise, it's really challenging to launch these into acquisition. So that was a great question, though.
Thank you.
Thank you. Everybody ready to keep going? I could talk about the language pairings all day. It's one of my favorite parts of the whole approach. So within the happy medium approach and happy medium language, we have a flexible treatment package put together. We have specific tactics that we've found that are helpful. We just talked about our language pairings. We have a 3-layer intervention competency assessment to support parents, registered behavior technicians, the behavior analysts, and then even like a little training level in our competency assessment. So are you able to train other people how to use this approach? We've got a treatment process tool. We've got program banks and supplemental material to support interventionists. And then we've got our 7-dimension program assessment, just to make sure that we're sticking to our behavior analytic roots. So within our treatment package, we have the noticing grid, which you guys already got to see. We have ABC skill access, which the best way to describe this is sometimes kids just wake up on the wrong side of the bed, or when you work with individuals who have low tolerance or challenges sustaining that level 1 on the noticing grid, sometimes their objective behavior is different from moment to moment or day to day. And we want to be able to tailor our intervention intensity to what they can tolerate and sustain that level 1 and level 2 on the noticing grid. Because again, we want to stay out of that extinction zone. We want to stay out of that level 3. I know this sounds crazy to hear a behavior analyst say, but I want to avoid those behaviors because no learning takes place in that zone. So instead, we want to provide intervention that's tailored to their tolerance level that day. And we want to support by shaping down that undesirable behavior. We're going to reinforce behaviors at lower levels so that we don't get to that level 3 and out of the engaged and learning zone. We want to create hierarchies of reinforcement so that we can deliver reinforcers at different levels based on presentations of skills. You know, so a kid might get more reinforcement for, you know, stopping, talking out loud, you know, labeling an emotion and demonstrating a coping skill than they would if they just, you know, were screaming out loud, you know, I'm so mad at you. We want to be able to teach them and give them kind of differing levels of reinforcement to show them which behavior worked better. We want to make sure we know what they like and what they don't like so that we can deliver a lot of what they're really enjoying, what their interests are, what their values are. And we want to be mindful of what's non-preferred so that we can arrange the environment in order to support their ability to sustain that level 1 and 2. So we're not going to deliver a bunch of kind of non-preferred tasks or non-preferred academics in a row, because that we know is probably going to pop them up to that level 3 on the noticing grid. And then we're in that kind of I'm not learning zone. We want to think very clearly about what behaviors we want to reduce first. And those are always the safety concern behaviors first. We want to reduce those behaviors so that that individual can sustain safety. And so then they can begin accessing more environments. A lot of the families we work with are home locked. Like they can't leave their home for fear of, you know, a level 3 happening at the grocery store, or the individual might be, you know, they might be in a kind of self-contained classroom because they can't access peers safely. And that's super limiting. So we want to be super thoughtful about how we're going to reduce those behaviors so that we can increase their access and learning opportunities. And then we have our distress tolerance hierarchy, which supports us in, again, delivering intervention at a rate that they can handle and at a level that's going to keep them learning, but not push them out of that zone to where we're not engaged in learning anymore. And we're going to be super planful about our use of negative reinforcement. We are going to teach these guys how to escape when they're at a level 1. We're going to teach them how to use language, how to take breaks, how to decline work, whatever it might be that they're looking for relief from. And we're going to be thoughtful about their history of trauma. We're going to learn as much as we can from them, from their families, from reports. And we're going to respect that as interventionists, we can only add to their learning history. We can't take away what's already happened. So that is going to make us thoughtful about teaching new and replacement behaviors. Go ahead, Sean.
Oh, I had to find the mute button. You're super quick on that, Rosalie. Could you say a little more about planned use of negative reinforcement? Because I think so often there's like an equal sign between negative reinforcement and bad for people that work with CAF populations. And I thought that was a really interesting way to frame it, because it's technically right. And so much of this sounds like you're trying to teach them how to behave in ways that are interpersonally effective. And so is there more that you could say just about what you would teach them when they're at level 1?
Oh, yeah, for sure. So thank you for bringing that up. That's just an exceptional question. And I think I do battle on a weekly basis with schools over that we're in. You know, like, why are you prompting him to say, I don't want to do that right now? And I'm like, well, because I can see he's starting to increase to a level 2 on the noticing grid. If I don't prompt him to use language to escape right now, we're going to have a level 3 and it could potentially become unsafe. So I can pop over to a couple of the noticing grids and you'll see a lot of the strategies are kind of escape strategies. You know, so we might teach an individual to access sensory activities, and a lot of schools and parents can feel like that is providing positive reinforcement for the negative behavior, whereas kind of within the happy medium approach, we view that as accessing a skill to regulate your emotions and come back down to a level 1 so that you can stay engaged in learning. Then we've got more opportunities to teach you when you're at that level 1. So, you know, this individual has, you know, ask for help from an adult, which could be like the removal of, you know, a, you know, social studies project that's overwhelming. He has take a break outside the classroom, any engagement activities. So we really encourage engagement as a strategy to get back to a level 1. When you can't kind of remove yourself from an overwhelming situation, it's kind of, you get to that fight or flight zone, which is that level 5. And then it's very challenging to get back to a level 1 and stay. So you got to stay engaged. Did that help answer your question a little bit more?
Yes, I think I'm picking up that a primary focus for you is on emotion regulation and being able to talk about that before you're too dysregulated to talk about it, and then you get to level 3s, right? So
yeah.
Smaller sooner, larger later. Like if you can say, yes, that's right, we're going to pause and take a step back to maintain emotion regulation or get it back all the way, then we get more engagement, right? Is this kind of what you're emphasizing? Okay.
Yep, exactly. Yeah, and here, let's look at the tips and tricks. I'll talk a little bit about that too. So we kind of have, and I can talk, I can kind of finish. We'll talk about the rest of these strategies kind of within. The only other little piece from this slide that I want to touch on is the team people files. It is so important to develop relationships with these humans that struggle with behavior and sustaining regulation, supporting them in developing relationships with the intervention team, because there's going to be some hard moments. Like there's going to be times where you get bit or hit or your hair ripped out or something. So we have team people files, which they're like a list of likes, dislikes, you know, favorite foods, birthdays, pets that everybody has, so that we can keep building that relationship around that individual. And then hopefully as they kind of sustain regulation, stay at that level 1, they're then able to use those skills to go out and develop relationships with peers and really have meaningful relationships and ways to engage with them. And then just for the intervention team, we do like a mini pro-social just to keep everybody on the same page and flexible, because it can get hard at times. So our tips and tricks and tactics are pendulum of optimal learning, which I've already talked a lot about, which is we want to stay in that middle zone, which is that engaged in learning, where we're seeing mostly level 1 behaviors with learning opportunities to successfully move to a 2, but get back down. When we have too many demands, or we don't allow escape when that individual is at, say, a 2, then we're probably going to end up in that kind of danger zone, that unsafe zone where learning doesn't occur. You're just waiting them out to calm down. They've got to ride that whole escalation curve. And then we've got our continuum of shared control, which supports interventionists in recognizing like it's okay to let that individual have a lot of control over the intervention initially. Almost always we kind of start with the individual, they choose what we're going to do, they choose the engagement, and then we'll gently work to move that continuum of shared control to where the individual can tolerate kind of doing cold demands. I'm going to use the word cold demands from an adult, right? That like you have to do if you get pulled over by a police officer, they are not going to share control with you. They are the boss in that situation, and you should probably listen. We need that. That's a whole nother subject, but helping that individual to develop the ability to move along that continuum of shared control and know that it is okay for us to allow the individual to be the leader in their intervention and what will work for them or not work. And then our distress tolerance hierarchy supports interventionists in thinking about what's a doable step. And I think I heard Catherine talking about that too. You know, how can we help this individual take, even if it's the tiniest step towards that goal? What is that tiniest step? And I think Dr. Hanley calls it micro shaping. But we want interventionists to kind of have this distress tolerance hierarchy in their head. So as they go to present an opportunity to learn, what's going to be a doable opportunity that isn't going to get us to a level 3 on the noticing grid. And then again, along the lines of the negative reinforcement is our drop the rope to stay in the engaged and learning zone. We need to avoid power struggles, especially with this population of individuals. There's no demand unless it's like a safety demand that's important enough for us to hold that demand instead of dropping it and helping them get back to a level 1 on the noticing grid and trying again at a doable level for them. Clearly we made a miss and that wasn't doable for them at the moment. So we want to circle back. Yes, go for it.
I feel sometimes scared that dropping the rope in a situation like this would be, for example, giving in and reinforcing on undesirable behavior. How would you differentiate dropping the rope to stay engaged in the learning zone from, for example, reinforcing a behavior that you don't want to reinforce?
Yes, so you will be reinforcing behaviors that you don't want to reinforce, but there are a set of lower level magnitude behaviors that are better than reinforcing those behaviors that are higher and dangerous. So you need to be collecting some data on, is the individual increasing their ability to sustain a level 1? Are they engaging more, or am I seeing more of these other behaviors? Because generally when we can support them at sustaining regulation, then we see less of those behaviors. So, and then they contact more reinforcement than they did when we kind of dropped the rope. So, but you do have to take some data collection on that to make sure that you aren't kind of increasing those behaviors in such a way that it becomes, you know, not good for your programming. Does that help?
A lot, thank you. I understand that us therapists have to be more flexible than just to win that power struggle, because sometimes, for example, I had a client that will once stay like inside the shower for 12 hours because his parents were not, for example, they were instructed by their physician at the time, do not let him win. If you tell him to take a shower, you guarantee that he'll stay inside the bathroom until he takes a shower, then he would stay there for 12 hours. And then I know, right? This is so I understand sometimes, like, when is the time to give up without making the client, that's a terrible way to say it, but like without making, like reinforcing the not complying for so long?
Yeah, so we can build an individual's tolerance to waiting us out, right? So that client learned how to wait his family out, because at some point he's going to have to go to bed. At some point he's going to have to go to the bathroom, or at some point mom and dad are going to have to go to work. So he's going to win using that behavior. So we would much rather say, all right, talk to me out loud about your worry about taking the shower. Let's see if we can come up with a compromise here. And instead of kind of that demand comply, we want to think about that shared control. What is the doable step here? I mean, at some point, a kid's got to get a shower is a health thing. So, but you want to kind of gently try to find your way there with shared control, rather than building up their tolerance to waiting us out. Like my favorite example, I held a demand and I had a kiddo running on top of a roof. No demand was worth that kid climbing a tree and getting on the roof of his house, where I then had no control over my intervention set, and that kid was not safe. So I think that's my favorite example to use. Like, I'm happy to drop any demand as long as I'm seeing those other behaviors come up. Like, am I seeing that kid approach the shower? Am I seeing him kind of start to do some of those behaviors that we want that would lead to getting into the shower? As long as I've got another way to get him clean too. Does that help?
A lot. It makes me more relaxed, because sometimes I think, okay, if I drop this demand, is me being weak? Because then, but then when you explain and you frame this into this is not worth it, then it's not me giving up, for example. This is me thinking more broadly into the whole repertoire that I'm trying to teach, not only into this specific struggle. So this is very helpful.
Definitely. Yeah, exactly. We're looking for that bigger, broader repertoire that's going to contact something that is going to lead to intrinsic motivation for that individual. Like, why do I want to take a shower? Not my parents just told me I'm going to take a shower. So that's what we're looking for, and taking baby steps towards it, which is that shared control piece. Go ahead, Sean.
Yeah. So kind of jumping off of that point, I'm wondering if you could speak more to how much of that drop the rope in particular, or really any of these, have to do with some of the characteristics of the populations that this intervention is targeted on. Because it sounds like there's a lot, these are kind of technical, but a lot of counterpliance, a lot of reactance to authority, and kind of maybe some biases that adults don't have their best interest in mind, or are just trying to manipulate them, that kind of a thing. Where a lot of those behaviors that you're describing, I don't like, it seems to me like the same rules don't apply. Like, you're not going to be able to do the same contingency management plan. It will backfire almost every time. How much of it is due to those kind of factors?
I think that's a huge point. Thank you for bringing that up. We often get individuals after a lot of failed ABA attempts. So parents will call us and be like we never made it past extinction. They're describing to me what extinction is, and yes. So I think the population that we serve is definitely that population that doesn't do well in those kind of demand comply without a why, like they want to know why you're wanting them to do that. And then also at the same time, the emotion load that they have around those contexts, probably because some of that history of intervention is so great. They've built this tolerance to like running away, waiting people out, fight or flight. Like that's a huge piece of this intervention, is supporting kind of that reduction of fight or flight so that you can access other behaviors. Did that help?
Yes, a lot. And it's almost like when I hear you say it that way, it's why would we ever do anything without a why? Why would a kid not ever be told that, right? So it's almost like for a lot of kids, we kind of get away with that, without putting that in.
Yeah, I think that's one of I have a lot of soapboxes, but that's one of them. Like, why would you just do something? Like, I don't do that in my day-to-day, life. So, I think that speaks a lot to our be kind. Like, no, these behaviors exist because they've been shaped by the environment and the contingencies around and, emotion loads and things like that. So, the individual is doing their best. Like, we've got to kind of meet them where they're at and support them in moving towards what's important to them, not just, complying to comply. And let's see, I'll jump up and show you guys some data. We have a lot of this is really complex programming. So we have a lot of decision trees to support providers in starting to kind of build their fluency with utilizing programming like this, because there are a ton of checkpoints. Like, am I going to present something now, or am I going to wait a little bit? Am I going to use negative reinforcement, or am I going to use positive reinforcement? So we have a lot of decision trees to support. Oh, this happened to me all day. I don't know what I hit that makes it go back like that. I apologize. Look at that. So our decision trees are for interventionists to support them in making kind of clinical decisions and then building that repertoire for themselves. And then we have our case conceptualization and treatment process tool, which after kind of the 3 stages would hopefully land us in a place that we can use traditional, like the Thriving Adolescent or Connect, DNAV, or ACT or Brief ACT with the individuals. So we have our foundational skills that set that foundation. Then we've got our kind of, how do we get going? How do we like set the stage for psychological flexibility? And then how do we access and practice that psychological flexibility in an ongoing way, which is what we all try to do every day, successfully or not so successfully sometimes. So we have a lot of different programming areas: distress tolerance, emotional regulation, engagement, shifting, flexing, things like that. But let me show you guys some data. We've already looked a little bit at the noticing grids.
Rosalie, can I just take a moment to tell you how wonderful it is to see maybe the thinking process of working with kids, like written down like this into like this, I forgot the name, like this map. Because quite often when we're teaching, for example, me and Ligia, we engage into teaching new child therapists.
Yeah.
And we do not have something like really mapped like this. And for example, sometimes you see new therapists trying to push an intervention even when the kid is deregulated just because they have this on their plans without really noticing. Nothing is more important to teach these kids to notice that this is not the moment to do anything else before they stop like regulating themselves. And then when you have this step-by-step, is so helpful for, and we know that especially for people who are starting, but not only for them, for us also, to really have like, because also when they are into level 2 or 3, especially 3 or plus, we also get into this deregulated state that is hard for us to focus on the functional analysis. And sometimes we get like sort of messed up too. So when you have this map, it's okay. So this is where I am. This is what I have to do. Is so helpful. Thank you for showing this.
Yes. I am thinking, how am I going to invite you to teach in my course, because I coordinate a whole master, and how am I going to invite you and translate your class? That's the only thing that I'm thinking about. How am I going to do the translation? Because you are invited for sure. That's all that I have to say. Thank you. That is quite an honor. I really appreciate that.
this programming, it's been 10 years, and I think we all struggle with a lot of the same things, right? Which is like, when you're an intuitive, and I call we're artists, right? Like, we take these tools that are, you know, research validated, but then we've got to implement them in changing contexts. So as you develop as a clinician, you develop those decision trees yourself. And before, what I was doing was I would have to be the one that people overlapped with in order to get them to use this programming. But now that it is written down, it's easier, but it's hard. I think our jobs as training other therapists, it's so challenging, especially for those that don't kind of intuitively kind of feel these levels. They don't notice these levels changing, and they don't notice their own level changing, like you said, which is massive, because when you've got dysregulated matching between a therapist and a client, we're headed to a bad place.
So much,
you know, and that's just not helpful to anybody. So
I love that point. Can I just riff on that for a second? Because I think that the art piece, what resonates with me about that is, like, when we're doing our art well, it just blends in. It doesn't seem like we're doing anything per se, you know, kind of the way that you just want your cell phone to work or something. Like, you don't need to know what's under the hood.
Right.
But here, either in training or when you need to engage your client or you need to engage other staff, you do have to have like an interface for that, right? For it to still be usable and non-technical, but it still contains everything. So I just think just want to also say how elegant I think this is.
Well, thank you guys. I really appreciate those kind comments. I've been in the middle of two worlds. I feel like my behavior analyst world and then like my ACT world. And a lot of times my behavior analyst guys are like, Rosalie, this is just a little out there.
Yeah.
And then my ACT people are like, this doesn't quite fit here either. Where is it? And I'm like, it's the bridge, guys. It's the bridge.
Yeah. I feel the
When
same
working
way.
with kids,
Let's hug.
when we're working with kids, only using the verbal part of it won't do it.
Right.
And when we look, because me and Ligia talk a lot, and what we see is when we were just behavior analysts, there will be this part of it that would miss, and we wouldn't know what until we met ACT and the contextual behavior sciences. But then when we tried to use this and only this with kids, it would be lacking some sort of more strategies that were really aimed to behavioral regulation and stuff like this, especially with ADHD kids. This is our main focus.
Yeah.
And then when you kind of combine them both, so you have sort of the structure of the behavior analysis, but with the flexibility mind of the contextual behavior sciences, then you can get to this more broad intervention that can try to reach both of the aspects of it all. So this is why it's so brilliant. And I always think when I see presentations done by people that are not CAF people, that they don't understand what we're talking about when we say that's missing something, that this doesn't work as it should with our population. So we have, in my understanding, we have to go back, and really look into the behavior analysis thing if we want to teach these repertoires, especially into this population that are not properly verbally developed.
Yeah, that was so well put. Exactly. Exactly.
Yeah.
Thank you. So here's some data just for you guys to quick review, and what this is practice data. So what you're going to see in most of these charts is that our variability starts to tighten up. And then we almost get like a slingshot effect. So the top graphs are going to be our percentage of 30-minute intervals that individual was able to sustain a level 1 on the noticing grid with, and then we'd have a criteria for how many times they could kind of pop to a 2 but come right back down. Because we don't want to, we have variability in our behavior. Sometimes we get to a 2, sometimes we get to a 3. So we don't need a perfect level 1 all the time, but what we need is a level 1 most of the time, with an adequate repertoire of skills to get back and then stay at that level 1. So you can see the frequency of level 3 behaviors coming down and our ability to sustain a level 1 tightening up. And then this guy just kind of slingshotted himself forward, which we see a lot where all of a sudden, everything kind of, they get it, makes sense. They've got a big enough repertoire of skills and they're sustaining a level 1 in a beautiful fashion. And this guy actually, he's off of his ADHD medication. He's 100% integrated in school with no supports at home. So that's a pretty fun success story. And then this next graph, this is an individual that has a very complex history, also has one parent with some very significant mental health challenges that affect him. They're almost like, they kind of co-regulate each other. In ways, it's an interesting relationship that I could probably talk about for 2 hours, but we see initially the first chunk of data is him in an isolated room in a school with free access to all highly preferred items. Like the school even removed the firewall so that he could access his games just to get him back to the educational setting. And you can see his variabilities tightening up. And then we make a huge transition from 5th grade to 6th grade, which in the United States, they transition between classes. So that's not just one teacher, not one set of peers, that's 6 different teachers, 6 sets of different peers. And he did an amazing job, went into the classroom independently. He just showed up at school saying, I'm going to do this by myself, Rosalie. And I was like, all right, sounds awesome. Let's see what's going on. So he did a great job for a while. And then we had a tank. But I think the great piece of this graph is how much shorter the period of time was for him to get back to sustaining a level 1. Whereas before it took a long time in a very contained, controlled setting to we're back at a level 1, pretty much integrated with our peers. So I think that was a pretty neat representation.
I have to be very annoying and let you know that our time is almost running up, even though I'd love to hear you like for hours.
Nope, I'll just show you guys these last graphs and we're good. Or do people have questions?
Thank you. I'm not sure people, do you have questions?
Because the graphs show very similar trajectories. It's just everybody's an individual. So their ability to kind of sustain that level 1 depends on, their context, basically.
Thank you. Should we open the floor for questions? I think we sort of made them during the presentations.
Yeah,
Lily?
I think I did. I think I did during the presentation.
Yeah, thank you guys for that interaction.
Rosalie, but I would love, thank you so much.
Definitely.
That was wonderful. Thank you so much for sharing. That was
you guys
amazing.
For listening.
And so thank you both, girls. I'm so glad with what we did here today. I'm so proud of creating this space of changing ideas and possibilities. And for you that are maybe watching after when it's recorded, please feel free to ask Rosalie and Catherine for questions in her emails, or even to write us to make yourself a candidate for one of our next events like this. It is great it's been like, one thing is the theory to sort of, I think people out there are doing interesting stuff that we should listen to. And the other thing is really looking at it, and we need more of this because both of you presented things that are so different, but also both of them so much a part of what we deal with when we're working with kids and adolescents. We work with this universe that's so broad and so different, and we have to deal with so many situations that come up for us. And the more we can learn about this different topics, I think the more prepared we are as clinicians and teachers, and the more we can, my motto is very techy, but it is to help the world one kid at a time. And I understand that when we exchange knowledge like this, we can broaden the the reach of our knowledge. So it was so helpful to listen to you guys, and thank you guys for being here too and to participate. Does anyone want to say something before we finish?
Just a huge thank you for offering yourselves up and stepping up. As we know, we're kind of following what we really believe is true here, is that there are voices from the CAF SIG that deserve to be amplified, and it's so difficult to put yourself out there. And yet at the same time, the folks that are out there in the ACBS community that work with CAF populations, like they've just done it, right? All on their own. So I think this for me has been an example of, like, I'm really glad that I did something that I had no idea how this would go. Not for the things that I expected to happen, but for everything that happened in our time together that couldn't have been predicted. So thank you. It's been incredible.
Okay, so Sean, if you'd like to stop the recording, I think, thank you everyone.